Suicide is always a potential, but given the proper training and its application, it need not be an eventuality. Suicide is the single largest cause of deaths in the nation's local confinement facilities. The suicide rate between police lockups, detention facilities, and prisons varies. The greatest magnitude of deaths occurs in police lockups, detention facilities next, and prisons approaching the same rate as in general population. The detention officer has a legal obligation to evaluate inmate risks and apply appropriate preventative procedures and contacts with inmates to minimize the possibility of a successful suicide in our system. We're going to discuss the misconceptions and facts of suicide. We're going to identify the periods of high-risk suicides occurring in the detention facility and give a reason for each. We're going to describe the factors in the detention facility environment that have an impact on suicide. We're going to identify and discuss symptoms of alcohol or drug intoxication. We're going to identify and discuss symptoms of alcohol or drug withdrawal. I'm going to list physical and psychological symptoms to look for and listen for in a potential suicide. We're going to discuss the importance of suicide screening. We're going to identify and discuss the basic questions or area topics that need to be addressed on any suicide screening form. We're going to list supervisory procedures to use with the inmates that are identified as high suicide risk. We're going to discuss the supervisory needs of inmates that are potentially suicidal, intoxicated, under the influence of drugs. We're going to define the term crisis. We're going to discuss communication and intervention techniques as it relates to managing people in crisis and interviewing people in crisis. Lastly, we're going to describe at least 3 immediate steps in the proper handling of an inmate who is found hanging. Suicides have a tremendous impact on staff and offenders in a facility. Indeed, suicides tear apart a facility emotionally, even when everything was done right and according to proper procedures. Suicidal behavior is costly, not only in terms of human lives, but also in dollars and cents. Hospitalization and legal defense especially can be burdensome to a facility. Many suicides in custody facilities can be detected and prevented. The following are some findings regarding characteristics of the suicide victim. 67% were white, 93% were male, with an average age of 35 years old. 43% were held on a personal or violent charge. 42% were single. 47% had a history of substance abuse. 28% had a history of medical problems. 38% had a history of mental illness. 20% had a history of using psychotropic medication. 34% had a history of suicidal behavior. The following are some findings regarding characteristics of suicides. 32% occur between 3:01 p.m. and 9 p.m. 23% occur within the first 24 hours of incarceration. 20% of victims are intoxicated at the time of their death. 93% of the victims used hanging as a method of choice. And why do you think that would be? Well, I think that would be because what other methods do they have? Especially if they're on suicide watch, all they have is what they're wearing. 31% of victims were found dead more than 1 hour after the last observation. 38% of victims were held in isolation, and 8% of the victims were on suicide watch at the time of death. 77% provided intake screening to identify suicide risk, but only 27% verified the victim's suicide risk during prior confinement, and only 31% verified whether the arresting or transporting officer believed the victim was a suicide risk. Now we're going to talk about some misconceptions and facts surrounding suicide. And this is suicide as a whole, not just in a detention facility. The first one is if a person talks about suicide, he won't do it. The studies show that a majority of persons who commit suicide made their intentions known to someone by either direct threats or implication. Number 2, if a person is unsuccessful at completing suicide, chances are he won't try again. The fact is that 80% of suicide victims had at least one previous attempt. The National Institute of Mental Health Studies indicate that anyone who has previously attempted suicide is 64 times as likely to take his own life than someone who has not. Number 3, a misconception is all suicidal individuals are mentally ill. The fact is, although some individuals with mental illness may have a high potential for suicide, it is not an act exclusive to mental illness. Many suicide victims plan and execute their deaths rationally and logically. A misconception is that there's nothing anyone can do to stop someone after they've decided to kill themselves. The fact is, most suicide victims are ambivalent rather than totally committed toward suicide. Many persons also have suicidal thoughts which they never act on. Number 5, the misconception is suicidal people want to die. The fact is, most people considering suicide have mixed feelings about killing themselves. They really do not know whether they want to live or die. Number 6, mentioning suicide might give someone ideas. That's a misconception, but the fact is, asking someone if he has ever tried to take his own life will usually result in one of the 3 responses. Affirmative, with a great sense of relief that someone is willing to bring it up. Negative, because they sincerely have not thought of it. Or negative, because it's a denial to self as well as to the interviewer of the presence of thoughts or acts which are accompanied by a great deal of guilt. There is no substantiating evidence that mentioning suicide will plant the seed. There is, conversely, strong supportive evidence that routine inquiry about suicidal behavior promotes communication and provides the opportunity for intervention. Misconception: suicide occurs most frequently in the world's general population than within the detention facility. The fact is, proportionate to the population, suicide occurs 3 times more frequently in a detention setting than in the world's general population. Number 8, misconception is that suicides happen suddenly and without warning. The fact is, most suicidal acts represent a careful, thought-out strategy for coping with various personal problems. Studies reveal that the suicidal person may give clues and warnings regarding suicidal intentions. 3 out of 4 victims make their distress known through actual threats, through discussing methods of suicide, through suicide notes, through the increased consumption of alcohol or drugs, and basic signs of depression. Another misconception is improvement after a suicidal crisis means that the suicide risk is over. Over 50% of suicides successful occur within 90 days of the crisis. This is a fact. The decision to commit suicide, once made, may decrease anxiety and produce a false improvement halo. So they may appear that they are getting better, but it's just because they've made that decision and they feel good about their decision, as messed up as that might be. Number 10, misconception is most suicide victims leave notes. And the fact is, only 15% of cases are notes left. Some are extensive, leaving instructions for the distribution of property and funeral details. Others apologize for the action or encourage the loved ones to start over with someone else. A misconception is that all detention facility suicides occur during the 12 midnight to 6 a.m. shift. And the fact is, although some do occur during the 12 midnight to 6 a.m. shift due to a perceived decrease in supervision and staffing, the frequency of suicide is fairly even distributed throughout the time of day. And in fact, in our facility, we don't go down in our supervision and staffing during that time frame. Number 12, the suicide is a logical end to an insurmountable problem. That's a myth. Fact is, although an occasional suicide may appear to be a logical solution, the majority of victims lack logic in that they are unable to formulate alternatives or viable solutions to their problems. They feel that this is the only way out of it. High-risk suicide periods. Experience has shown that there's a certain high-risk suicide period for the inmate, which correlates with phases of incarceration or steps in the criminal justice process. These periods include the first 24 hours of confinement. This is a crucial period, specifically the first 3 hours, according to the National Center on Institutions and Alternatives Incorporated studies. The intoxication, withdrawal, or sobering up. Approximately 62% of inmates who commit suicide have a history of alcohol and drugs. Although alcohol is initially a stimulant, its effect is limited, and it soon becomes a depressant for many people, particularly those who drink because of problems. Substance abuse is a key indicator of potential suicide. People under the influence of alcohol or drugs do not think rationally. Also, hallucinations or delusions may occur and may cause people to act in a dangerous manner. So the hallucinations and delusions, they may occur during intoxication, but they also happen during withdrawal and sobering up. So that's all a dangerous time. Waiting for trial. The agony of the unknown and just plain waiting produces great anxiety and pressure on many people. Many people start thinking way too much about what's going on. They've got nothing but time when they're here. So while they're awaiting trial, they start thinking of all the horrible things that can happen because of this trial coming up. Sentencing. The day of reckoning, particularly when awaiting or responding to a sentence just handed down, constitutes the breaking point for some inmates. Included in this group is a serious repeat offender who knows what kind of life to expect in prison and cannot bear the thought of returning. Impending release. This phrase catches many detention officers' staff off guard because, like ordinary people, we consider that release from jail is something to look forward to. The problem is, for a suicidal inmate, the stigma of facing family and of friends and fellow workers upon release may be too great. Severe guilt and shame outweighs what ordinary people see as the positives. They also may feel that they may have lost their job while they were inside. They may have lost a family member or lost a marriage. So those things, they don't know what they're going out to. And sometimes the relative safety of a jail would make impending release scary for them. Holidays. Holidays often mean loved ones gather together. This adds to the loneliness of confined persons. Personal holidays such as birthdays and anniversaries can be tough days for some inmates. Incidence is higher during the Christmas holidays and in April and May. Holidays reinforce the concept of family, friends, and togetherness. For the majority of people, holidays imply happiness and well-being. Feelings of depression and despondence may increase as one observes others experiencing togetherness and well-being. It's believed that the rebirth and renewed hope most people feel in the spring of the year reinforces hopelessness in others. Suicides have been known to most often occur on Fridays, followed by Mondays and then Sundays. Again, Fridays symbolize plans and friends. Often it's payday. Depressed people may not have these things to look forward to. Darkness. Since suicide is a very hours of darkness with an accompanied decreased staff support produce many suicides between 12. However, the frequency is even the day. Decreased staff supervision. Many jails have less staff on duty during weekends, nights, and holidays. Fewer programs and activities also affect the jail atmosphere. So for us, we have the same amount of staff on weekends, nights, and holidays, but we do have fewer programs and activities and nights and maybe holidays. Bad news of any kind. Arresting officers, detention officers, and mental health workers should be aware of some crisis which can greatly disturb an inmate. Some examples are Dear John letters, a restraining order by a wife prohibiting the husband's return home, losing a job, a notice of foreclosure on a home, a death notice, divorce proceedings, visits or lack of visits, and disturbing news of any kind from loved ones or an assault. Recent loss of resources. This includes loss of a loved one, a job, a home, or finances. And then the suicides often follow other suicides in jail. Factors of the detention environment which are conducive to suicidal behavior. From the inmate's perspective, there are certain unique characteristics of jail and environment suicidal behavior. Number one is the authoritarian environment. Persons not used to being regimented can encounter traumatic difficulty in the jail setting. So they're being told what to do, when to do it, how to do it, when they can eat, when they can go to their cell, that they can't leave their cell, things like that. So that's a very hard environment. Number 2, no fear, including fear and uncertainty over the legal process. Following incarceration, many jail inmates experience feelings of helplessness and hopelessness. They feel powerless and overwhelmed. Number 3 is isolation from family, friends, and the community. For incarcerated individuals, support from family and friends may seem far away, especially restricted visiting and television, and in our jail they cannot have visitation that is where they can touch each other, so that's going to restrict it even more. It's always through the glass and always over the phone. The shame of incarceration. So feelings of shame are often inversely proportionate to the gravity of the offenses committed. Frequently, such feelings develop in those persons who have never been arrested before or who have a limited arrest history. In an NCIA national study of jail suicide, 75% of victims were arrested for non-violent offenses. It is not uncommon for jail suicides to be committed by individuals who have been arrested for traffic violations, disturbing the peace, or other minor offenses. Dehumanizing aspects of incarceration. Viewed from the inmate's perspective, confinement and even the best of jails is dehumanizing. Lack of privacy, association with acting out individuals, inability to make your own choices in the regulation of your life, strange noises and odors can all have a devastating effect. Many facilities are old with a substandard environment. Common overcrowding creates stress. Fears. Fears based on the stereotypes of jails seen on television and in movies, and stories reported by various media and acquaintances heighten the anxiety on the part of some individuals about other inmates and sometimes about staff. So think about the media that you've seen about jails and movies, things that happen. How would you feel coming into a jail environment? What would you think would happen to you? Think about that. So it's the fear of the unknown for the first-time offender. Fear of the known, so they've been here before and they know what to expect. Fear of other inmates and detention officers, and fear of closed spaces. 5 key reasons. The impact of alcohol or drug abuse on a suicide risk. Detention officers probably have to deal with persons under the influence of drug and alcohol. Compounding the difficult situation is the strong relationship between substance and suicide. Regardless of whether you view alcohol or drug abuse as a symptom or a disease, they distort a person's perception of reality and can lead to a depression or suicide. It is paramount to realize that when someone is high on drugs or alcohol, he is a very serious suicide risk. So 5 key reasons for heightened suicide risk are intoxication. Persons under the influence of drugs or alcohol do not think rationally. We talked about that earlier. They are likely to become anxious and depressed and are much more prone to panic. Simultaneously, they become less inhibited and are more likely to do things they wouldn't ordinarily do. Because of the combination of these effects, they are likely to act in a more destructive and inappropriate way. Shame and fear. As the effects of the drug wears off, the full realization of the inmate's predicament becomes apparent. He is in a detention facility. He may also be scared, depressed, or ashamed that suicide may seem to be the only way out. Detoxification or sobering up. Alcohol, especially if the person can be so uncomfortable or painful that suicide may seem like the only relief available at the time. They just want the pain to end. Hallucinations and delusions. Some drugs cause hallucinations and delusions, seeing things or hearing things which aren't there. This might cause people to act in a manner dangerous to themselves or others. Hallucinations and delusions can occur during the intoxication or when the person is coming off the drugs or alcohol. And then the masking effects. Sometimes a person who is high on drugs or alcohol actually has other problems that are not evident when he's high. Only when a drug effect wears off do the real problems become clear. Some people who are psychotic or very depressed will drink or take drugs as an escape from their problem. They self-medicate. When the alcohol or drug wears off, you might then have a serious suicide risk because of the psychotic revealed. Signs of alcohol and drug intoxication. You are most likely to encounter the intoxicated person at booking. It is therefore crucial that signs of intoxication. Some of alcohol or drug intoxication include slurred vagueness, confusion, so you ask them questions and they can't really, disorientation, they don't know where they are, they don't remember what they've done, sensory motor impairments, they really can't do fine motor skills, redness or puffiness around the face and neck as a result of fluid retention, dilated capillaries, or high blood pressure, mood changes, be more likely to be very irritable, euphoria, so they're inappropriately happy, or they're depressed and excessive and inappropriately depressed. They may have multiple bruises because due to accidents or impaired blood clotting because of their alcohol or drug intoxication. They may have burns or discoloration of fingers due to unawareness of falling asleep while smoking, loss of feeling in outer limbs, or from smoking joints. They may have pills that they're taking. They may have needle marks depending on how they're taking their drugs. Those are all things that you can look for to, and it's not every single is all going to be together. It just depends on what people are taking and what you might see. So prescribed stimulants have recently been seen in younger generations as a cheaper means to a high, stealing prescriptions from family members, friends, and others, and then ingesting them in higher than prescribed quantities. So that is why we have the drug drop-off here in the front lobby, so that we can hopefully avoid people getting our drugs that we're no longer using. The high from this form of abuse can take longer to initiate. The high tends to be longer lasting than other illicit stimulants such as cocaine because they are prescribed, so it has to go through the digestive system, it has to be absorbed. Common effects are an increase in alertness, greater confidence, feelings of power, and excitement. Common behavioral and physical traits are very similar to cocaine. They can show signs of talkativeness, irritability, euphoria, high energy rates, increased pulse rates, and dilated pupils. Cocaine use. Cocaine, whether in powder form or cracked, is one of the most well-known and commonly abused stimulants next to meth. Cocaine is extremely addictive, and current studies show that almost 2 out of 10 people who try the drug develop serious dependency to the drug. Physical signs and symptoms. See on that picture, the pupils are huge compared to the color. So, lots of light in a room, their eyes will still be very, and that's unusual. Possible a runny nose, chronic nasal problems, or bloody nose, because depending on how they take the drug. So if they snort the drug, there are nasal passages and they are creating runny noses, bloody noses, things like that. So if they inject it, they may have, and that's basically scar tissue that shows up themselves in the same place. Dry mouth, lip licking, and constant thirst just because it is a stimulant. Red, bloodshot eyes. Increased body temperature result in shivering or the chill. And then an increased pulse and blood pressure. Again, because it is a stimulant, it's going to increase the pulse, it's going to increase the blood pressure. And see them behaving. They're going to be irritable, anxious, or on edge. They're going to be erratic or quickly changing behaviors and having mood swings. They may have periods of deep depression as the cocaine wears off. They're going to be paranoid. They may have an inability to sleep or be very restless because, again, it's synthetic, so they're not going to be able to sleep well. Rates with thoughts and patterns. Are derived from as an analgesic, which is a painkiller. The most common naturally derived narcotics include morphine, codeine, heroin, hydrocodone, and oxycodone. Synthetically derived narcotics include fentanyl, methadone, and pethidine. Now, you may see some of these mixed together in some of these drugs. So recently we've seen heroin laced with fentanyl. So you've got a double narcotic on that one. Physical signs and symptoms. Sedation, so they're going to be very chill, basically. Respiratory depression, which means that they are not breathing very often, or they're breathing very shallow, because what it does is the opiates tell the brain to, if you have too much in there, it will calm down your breathing, and it'll start telling your brain not to breathe. So that's how it kills you, because it depresses your respiratory center in your brain to the point where you just stop. So you see the pupil on that picture right there. It is a very, very tiny pupil, and again, not dependent on the light in the room or outside. Even if it's completely outside, they will still have pinpoint pupils. They'll have nausea and vomiting, possibly. They could have itching skin, flushed skin, and then needle marks, again, because of how they might be taking that drug. And how are they going to behave? Confusion, poor judgment, may have euphoria, slurred speech, may have mood swings, and what they call somnolence. Also, they're spaced out, they're sleepy, they're drowsy. This is getting to the point where they're going to sleep for a while. We have to watch those because sometimes they have taken too much and they may overdose, and then they are unconscious, not just sleeping. Methamphetamine. Methamphetamine users, you may see them having weight loss. Even a small amount of methamphetamine can result in a decrease in appetite, and they won't eat for days. A loss of teeth is caused by the grinding of the teeth and decay due to poor hygiene and malnutrition. They often call this meth mouth, and it's very obvious how, but it'll be younger people that should not have lost their teeth, but it's because of the meth use. They'll have a body odor, results in the chemicals used through the manufacturing process being released through the user's pores. Meth users often look older than they are. They have dilated pupils, again because it's a stimulant. They have track marks if they inject it by needle. Sometimes they smoke it, it just depends on how they want to take it. They have abnormal sweating and body sores. This is the hallmark that you'll see here. So they feel like there are things under their skin, and they scratch and scratch and scratch, and they end up having body sores and ulcers. Behavioral clues. What are you going to see? Well, incessant talking, irritability, increased activity. They're going to have problems sleeping, so they're living with a meth addict is nearly impossible because they never sleep. They may have a heightened sexuality because they participate in bizarre sexual activity beyond their norms. Twitching and hyperactivity, it damages the brain in the same way as Parkinson's disease, so even if they're off the disease, they're still going to have changes in their brain afterwards. Repetitious behaviors such as picking at the skin, pulling out the hair, compulsively cleaning, grooming, or disassembling and assembling objects. So the picking at the skin is why you see all the sores at various degrees of infection and things like that. Withdrawal from society, friends and family may become enemies. Changes in friends, they're obviously going to have friends that will do the same things as them. And then deceit or secretiveness, because they are trying to get the drugs at all times. That's what they're going to live for. They're not doing the normal things that we do. Psychologically, they're going to be paranoid. They're going to have anxiety expressed as irritability, excessive talking, fidgeting, restlessness, and impatience. They're going to have aggression, agitation, and violence. Hallucinations and delusions of insects crawling on the skin. That's why they pick at their skin, and they refer to this as meth or crank bugs, because it just feels like they're crawling on their skin at all times. They're going to have nervousness, extreme moodiness, and severe depression. There's a really good website that you can look at called Faces of Meth, and it just shows pictures of how people changed from the first time they came into the jail, like their first mugshot, to how they progressed in the drug, and sometimes it's only 6 months for them to really look horrible on the drugs. Now we're going to talk about symptoms of alcohol withdrawal. It's critical to note at booking and during the first 48 hours of incarceration whether or not a detainee is under the influence of alcohol. Alcohol has a strong relationship with suicide. We'll spend a few minutes focusing on alcohol information. Alcohol withdrawal, which presents as both serious medical and psychological problems, heightens the risk of suicide. One of the most frequent and difficult conditions of withdrawal is the person with the delirium tremens, DTs, sometimes called the shakes, the tremors, the rams. They usually occur 72 to 96 hours after the inmate has had his last drink. With the DTs, the person becomes delirious, disoriented, and imagines he's seeing terrifying things and have horrible hallucinations. They may think that they hear things too. In addition, he has severe tremors. His tongue, his hand, even his whole body shakes. He may have a high fever with convulsions, vomiting, and severe swaying. DTs is a very dangerous medical condition. If not responded to by hospitalization and/or medical treatment, it can be fatal. The inmate experiencing DTs must be closely watched because sometimes, in trying to escape the frightening delusions or hallucinations, he may kill himself. Also note that a person can have delusions and hallucinations without having DTs, and it happens often with alcohol. A stimulant withdrawal. So withdrawal from any illicit drug should be considered a medical emergency. The severities of the symptoms vary from person to person based on body makeup and length of drug abuse. Like methamphetamines, the withdrawal symptoms of stimulants are much less definitive than opiates and alcohol. Withdrawals can begin as quickly as hours after the drug has left the body, and usually the physical symptoms may last up to 7 days. The drug cravings can last as long as 10 weeks. They include fatigue, dehydration, dulled or slowed motor skills, chills, insomnia, anxiety and agitation, vivid drug-related dreams, and interpersonal withdrawal. Narcotics withdrawal. Narcotics withdrawal periods vary from person to person, but the worst part usually lasts 7 to 10 days. The anxiety and strong desire for the drug. They have watery eyes, watery discharge from the nose, and are yawning a lot. You'll see dilated or enlarged pupils of the eyes, aching of their whole body, severe shakes, hot and cold flashes, possibly a fever, high blood pressure, fast pulse, rapid breathing, diarrhea, vomiting, low blood pressure, and dehydration. Methamphetamine. The physical symptoms of methamphetamine withdrawal are much less than alcohol. However, the psychological effects can be much worse. When compared to cocaine or other stimulants, methamphetamine has a more intense and severe effect on the body during withdrawals. They include extreme fatigue, disturbed sleep for long periods or insomnia, mental depression, dangerous psychotic reactions which can lead to violence or bizarre behavior, high anxiety, flu-like symptoms, so the body aches, severe drug cravings, and dehydration. So, symptomology of physical and psychological potential suicide. The pressures and stresses of today's world are intense. Add to this the additional circumstances of being in a detention facility or lockup, and suicide becomes an all too often outcome for people in crisis. Here are the important signs and symptoms to look for that might indicate that an inmate is at high risk to attempt suicide. The clues to a potential suicide may be overly physical or of a covert, indirect psychological nature. Physical signs and symptoms. Physical manifestation of depression. 70 to 80% of suicides are associated with depression, including sleep difficulties, slow movement, slumping, frequent crying, weight loss, and appetite loss. They may have unrealistic illness complaints, such as they say their heart stops. They may have vague illness complaints, trembling and paleness, high levels of anxiety, or a prior suicide attempt. We like to say that past behavior predicts future behavior, and in suicide that's just the same way. Psychological signs and symptoms. Things to look for and listen for. Sudden mood changes. If a person suddenly is happy and calm after appearing depressed, they may indicate that a person's decision to commit suicide. They may have emotional outbursts. Apathy and despondency. They have no interest in others or activities or have low self-esteem. They may have a projection of hopelessness and self-doubt. They may speak of getting out of jail unrealistically. They may have a preoccupation with the past. They may have increasing difficulty relating to others. They may withdraw from people and have no interest and no energy. They may begin giving his possessions, asking questions about death, estates, and wills. They may have an overt mental disorder of symptoms like loss of reality, paranoid ideation, and manic depressive episodes. And they may just be agitated. Other warning signs. Well, talk of suicide, including I have no future, I don't enjoy anything anymore, at times I wish I was dead, and being pessimistic about the future. A recent critical loss, such as the death of a spouse or the marital breakup, job loss. Excessive shame or guilt, possibly about the crime committed. Psychiatric history, problems with alcoholism, mood disorders, schizophrenia. Very few close friends and family. A family history of suicide, being alone in the world. And difficulty carrying out routine tasks like getting dressed, eating, washing. An invaluable way to look at an inmate's potential for suicidal behavior is to think of it as a product of three important aspects: the way an inmate is feeling, his external environment, and the detention lockup environment. So the way an inmate is feeling. A person's behavior is determined a great deal by what's going on in his mind. This is commonly called the intrapsychic world. This consists of the thoughts and feelings that he has. And a person who is potentially suicidal, these thoughts and feelings might include extreme depression, guilt, shame, ambivalence, failure, hopelessness, very low self-esteem, unresolved conflicts, no meaning in life, fears including and especially the fear of incarceration, anger, and alterations in thoughts and feelings caused by mood-altering substances. External environment. A person's behavior is also determined by the environment he comes from. Environment such as home, school, or job, but also to what has happened between a person and other important people in his world. This means that critical environmental issues may contribute to someone being potentially suicidal, such as marital breakup, death of a close friend or relative, loss of a job, failure at school or work, no money, loss of community respect, public stigmatization, and inadequate living conditions. The detention environment. Of particular importance for your job is the situation people are, the employee are dealing with them, the detention environment. If an inmate comes into custody with existing intrapsychic and/or environmental problems, making sure that the detention environment minimizes further suicidal potential is critical. It is crucial to be sensitive to the inherent stress of incarceration. Keep in mind these stressful aspects of the detention environment. There's been a great deal of change in a short time frame by going from freedom to incarceration. The inmate faces uncertainty about his fate. Will he make bail? What will his sentence be? How will he be treated? Isolation from family, friends, and the community. He's now in an authoritarian environment where he has lost his personal freedom and feels he has lost control over his life. He is now limited to a restricted physical space, minimizing his opportunity to choose how he will interact with others. And he faces the absence of sexual satisfaction as well as the threat of unwanted sexual contact. Levels of cues. As you will review the levels of cues for suicidal indication, you will see that the intensity increases with each level, with level 3 being the most serious. Level 1. They are generally unhappy. They seem to have depression, withdrawn, isolation, acting out. They have family problems and few resources, social isolation, or school problems. Level 2. A recent change in behavior, including weight change, changes in sleep, or changes in appearance. Recent change in situation, loss of a pet, friend, or a marriage. And carelessness, personal habits, risk-taking, thrill-seeking. Level 3. Thinly veiled comments like, I'll get even, or I'm just a burden. Contact comments like talk of suicide of others. Suicide-related acts like giving away prized possessions, collecting guns, drugs, etc. Questions about the hereafter, and question statements like, how many aspirins does it take to kill a person? This is the last time you will see me, etc. There's not a slide for this, but we're going to talk about suicide screening. Most of you will never do this sort of thing, but I just want you to know what it's about. So it's imperative that each agency has a suicide prevention process, including a screening form that's developed, and there are policies and procedures which address its use and application. The suicide screening must take place at the time of booking. Suicide precaution comes into effect anytime you become concerned that an inmate poses a suicide risk. Time is crucial. Early detection could prevent a possible suicide. You are not being asked to make a diagnosis or a prediction. By using suicide prevention guidelines correctly, you will be assisting in identifying suicidal risk. Then your department must have necessary steps and procedures to take in order to avoid the crisis. This should be part of your policy and procedures manual, and it is. So if we identify someone as being a suicidal risk, there's steps that we take, such as putting them in isolation so that they are watched at all times, or are they put into a cell by themselves without clothing and just their suicide blanket. We take their items, any items that could be used to hurt themselves, things like that. We have a screening form. It's divided into observations of the transporting officer, personal data, behavioral appearance, and criminal history. All detainees are asked these questions, and it's a routine procedure. Some questions may be personal, but they are necessary and required. You cannot force someone to respond, but you can encourage communication by showing respect and employing the skills that you will learn. When someone does refuse to answer a question, you must note it on the screening form. Be sure to ask all questions, even if the detainee is initially uncooperative. As you ask the questions, it's possible that they will eventually respond. If someone refuses to answer all questions, you cannot assume that he has a problem in any particular area. You do not score answers as yes. You simply write refuse to answer on the far right side. In this case, you will have to rely on your observations, training, and experience to assist you in deciding how to proceed. It is better to be too cautious than to ignore a possible risk. If someone's intoxicated or unconscious, they will not be able to answer these questions. And note that. Remember, inmates who fall into the category require constant supervision anyway. Officers are reminded that once an inmate is able to answer questions, the screening form, and other medical information. If they do not speak English, we must get an interpreter for this purpose. In the screening process, if you ever feel that someone is possibly suicidal or you're not sure, talk to your supervisor, see what they say, and they will make a determination whether that person is suicidal and get them on the right path to being protected. Management of a potential suicide. When a situation arises where you believe that someone's symptoms or suicide threat may be false or an effort to manipulate you, you still have to act and proceed as if it's real. Believe they are suicidal, you should stay with them. We do not leave a suicidal person alone if you think there's an immediate danger. Stay with them until you have other help. Maintain contact and conversation. Do not be reluctant to express your concerns about the person. Listen patiently. Encourage the suicidal person to talk and express feelings. Make a verbal contract with the person not to hurt himself until seen by a mental health professional. I don't like that verbiage. I would say make a verbal contract with the person not to hurt himself and to accept help. If you believe a detainee is suicidal, you should not ignore symptoms. Don't let others mislead you into ignoring suicidal symptoms. And we all know who people like that are. They're like, oh no, they're just bluffing, it's okay. I would rather be on the side of caution and on the side of the inmate than saying, I think they're lying. Let a professional decide that. Leave the individual unattended. Don't ignore the suicidal risk or threat. If you feel uncomfortable with the situation, get help. Just don't ignore it. Don't place the individual in a cell unsupervised, no matter how unruly or abusive he might be. He might be placed in a cell by himself, but the officer should be continuously supervising, and we have those policies and procedures in effect. Offer solutions, but don't get advice, and don't invalidate the person's feelings. Like, things really aren't that bad, you don't really want to kill yourself. Don't become angry, judge, or threaten the individual verbally or physically. Don't criticize, even if they're doing the same thing with you. Don't become the problem. Don't act sarcastic or make jokes about the situation, and don't argue with them. Don't encourage the individual to feel guilty for feeling the way they do. They can't help how they feel. And don't challenge the individual to make good on their threat. North Carolina law requires detention facilities to take reasonable steps to protect a inmate if there is reason to believe that he or she might commit suicide. Liability will result if we do not protect an inmate who has been identified as suicidal. 14J 0601 states that officers shall directly observe at least 4 times an hour an inmate who displays the following behavior: physically hitting or trying to hit an officer, being verbally abusive, stating he will do harm to himself, is intoxicated on a breathalyzer, or displaying slurred speech or smelling of alcohol, or inability to control body movement, or displaying erratic behavior such as screaming, crying, laughing uncontrollably, or refusing to talk at all. In addition to displayed behavior, a previous record of suicide or a previous record of mental illness shall warrant observation at least 4 times an hour. In addition, the jail standards require each sheriff to adopt a written operations manual that addresses the mental health needs of inmates. That requirement shall be interpreted to include the needs of suicidal inmates. Supervision standards require employees to carefully watch inmates who are known suicide risk. The written medical plan must address the handling of emergency mental health problems, which frequently will include a suspicion that an inmate has suicidal tendencies. Detention medical personnel and employees shall be trained to identify suicidal inmates and respond. Inmates must be screened, classified, and supervised in a way to reduce the possibility of suicides in the detention facility. Each newly admitted inmate receiving and screening process for his or her potential suicide risk. There is a potential for substantial liability if a jail lacks the comprehensive procedure for responding to the needs of suicidal inmates. Other preventive measures. When looking at your be sure the following steps are addressed. Staff training, such as this. Identification and screening, so they do that at intake and in medical. Staff communication. Housing, supervision, intervention, reporting, and follow-up. We have to create systems within the detention facility that identify inmates needing special attention, including intake and diagnostic procedures and special programs. We employ medical and psychological programs that allow the staff to have quick and easy access to their patients. We divert intoxicated individuals to alternative services. So we don't take anyone into our jail that's actively intoxicated to the point that they can't function. We have to ensure that there are proper staffing levels at the detention facility, and so that we can have 24-hour sight and sound supervision of all inmates. We have to have written policies and procedures for detection, assessment, management, and supervision of suicidal inmates. We have to prohibit the use of medication if at all possible. Inmates exhibiting suicidal behavior should be kept under 24-hour supervision. We have to urge the use of the interior detention facility design that does not lend itself to easy suicide, which I think. We don't substitute cosmetic precautions such as barless windows and doors, tearaway blankets, and television monitors for much-needed human interaction and constant supervision. Investigation of all suicides, which not only make officers accountable for lapses in security and judgment, but leads to an understanding of the system's flaws. Have to have an increased use of pretrial release in localities and counties throughout the United States, which may reduce the number of detention facility suicides annually. In one facility where pretrial release is used, results are impressive. In Tucson, Arizona, Pima County saw a 90% decrease in suicide attempts and completed suicides since implementing a pretrial release program, which we have. Public intoxication and other alcohol-related offenses should be placed in alternative services like detox centers. Where decriminalization of public intoxication has been adopted, a mandate should be more strongly enforced, which we've done these things. We have programs for the public inebriates should provide a wide range of support services following detoxification, and lockup facilities should employ a screening form at the booking phase and to identify potential suicide victims, which we do. So your role. An employee is as much a behavioral specialist as they are a provider of control and custody. You are asked to deal with scared, intoxicated, depressed, and suicidal. You also come into contact with many people who have post or current mental disorders. You as an officer maintain discipline as well as uphold the public's trust. You are the primary liaison between the inmates and the world. Since you have more contact with the inmates than anyone else, you must become an identifier and interpreter of problems. The management and prevention of suicide is a critical area in which the officer can be the difference between life and death. The detention employee should be aware of the symptoms ordinarily displayed by an inmate prior to a suicide attempt. Be tuned in to the obvious and sometimes subtle signals which every inmate sends out. Daily contact. Make it work for you. By making an effort to notice any behavioral changes that an inmate displays, you may be able to prevent an unnecessarily death. Be empathetic. Don't be judgmental. You are responsible for the welfare of inmates under your supervision, not for judging their moral character. And don't give up. If a person appears to be resisting help, do not be impulsive and withdraw the help and interest you've shown in them thus far. More often than not, an inmate's resistance is relatively superficial and will usually disappear gradually if you remain consistently sympathetic and helpful. And for those of you that work with our officers who identify this, understand that they are watching those inmates every day and they do know them very well. And just take the cues. If they tell you something's different, take notice of it. If you do notice, and you're not medical, if you do notice that someone appears to be suicidal, you have to let someone know. Shift supervisor is a good one. Medical's another good one. They need to know that these things are happening so that they can follow up. Consistent with national standards, departments develop 2 levels of supervision for suicidal and special needs inmates. Constant watch for those that are actively suicidal by either threatening or engaging in the act of suicide. This inmate's observed continuously on an uninterrupted basis. Close watch is for those inmates who have expressed thoughts of suicide and have a prior history of suicidal behavior but are not actively suicide. So we have the pink cell for those inmates that are actively engaging in trying to commit suicide. And then we have what we call suicide watch, which is the close watch for behavior, but they're not actively suicidal. If you identify people that are at risk for suicidal behavior, then you must follow our policies and procedures that outline our actions. Remove items that could be dangerous. This includes, but is not limited to, plastic bags, pens, belts, matches, shoelaces, scarves, drawstrings. Cotton sheets should be replaced by paper sheets, which we don't use. Any article of clothing that could be used, such as t-shirts, shirts, pants, any sharp item must be removed. Eating utensils should be removed immediately after use, and actually in our facility they get a suicide spoon. Inmates must be observed while eating. This can include beds, pipes from which the sheets could be tied, mattresses, pillows, and linens. Be continuously searched. So basically we take everything from them except for their suicide gown, so that they have nothing else. We place inmates in a confinement unit that once an inmate's been placed on suicide precaution, they should remain so until they are by the detention facility physician or other authorized person like a psychologist. All medicine should be administered under direct supervision of staff, and if we can, it should be liquid, but I know that's really hard to do. We should provide social contact. It's known fact that contact with another person is a deterrent to suicide, and placement with another person doesn't absolve the detention officer of primary responsibility. Be aware that potential suicide weapons and opportunities such as medication. Establish and maintain good rapport. Maintain communication with other shifts and personnel. Conduct rounds at unscheduled times and often, and record all observations. The North Carolina rules and regulations require 4 times per hour. However, it is recommended that they be Make referrals for all suicidal behavior to mental health. Every department should have a mental health plan developed, and our medical staff does. Document all information and actions. A watch sheet is a record of an inmate's behavior that is updated on a regular basis by the officer or health services personnel. This alerts all staff that an inmate is in need of additional supervision and ensures that an inmate will be observed at fixed intervals. Entries on the sheet should actually record the inmate's behavior and give information which can be used to assess the inmate's mental health. Entries should be initialed by the officer. These sheets should have an end date at which time appropriate mental health personnel review the inmate. The inmate is identified as high risk at 24-hour surveillance by mental health staff or volunteer cell. Restraints should never be used as punishment, convenience of staff, or substitute for treatment. The use of this should be strictly governed by written policies and procedures developed by mental health professionals to include a psychiatrist. Crisis management. Inmates in crisis. A crisis is a brief period of distress precipitated by a situation that the person's usual coping technique cannot handle. The first phase of the crisis consists of a person's initial reaction to failing in his or her attempt to overcome the disturbing circumstance. Managing people in a crisis situation. Try to calm the individual and relieve anxiety by being calm, confident, firm, fair, and reasonable yourself. Explain things. How do you see the problem? What is being done? And what the outcome will be. Encourage the inmate to speak freely within limits. Don't threaten. Encourage the inmate to express feelings and to relate to you. Remove the inmate from the scene of the crisis when other persons are present, as there may be a psychological contagion. Avoid arguing. Help the inmate structure the experience so that it's not chaotic and it does not appear unusual. Do not be sarcastic, do not lie, and do not make promises that can't be kept. An inmate that is suicidal or experiences a crisis should be referred to the appropriate mental health personnel as soon as possible. Suicide attempts and mental crisis are serious, and regardless of your feelings about the inmate or the crime, you are not to belittle them. Interaction techniques. Interviewing. Effective interviewing skills facilitate both the identification and management of detainees or any person in a crisis. There are 4 key areas to effectively interviewing. Attitude. The best way to get others to respect you is to respect them first. Unless you convey this attitude, you will not get accurate information from the detainee about his situation, and this makes his safety and everyone's safety all the more precarious. Keys to attitude is being respectful, being considerate, and being direct. Feelings. A very critical part of learning about a detainee's level of risk is not just what they say, but how they feel. Very often, what one says does not tell you how one really feels. Also, it is important to remember that how you might feel in a given situation is not how someone else might feel. You need to find out how the detainee feels. Keys to feelings are: be accepting of the person and his or her feelings. Offer your attention by putting down your work and face the person. Observe their behavior. Look for body language and other cues. Silence is okay. It often encourages people to verbalize if it appears that you are interested. And be sincere. Clarify. It is important to make sure that you understand what the detainee is saying. Even if you believe that you understand someone's answer, you should try to get the clearest answer you can. Instead of just guessing or repeating the question, there are some useful skills that you can get the detainee to tell you more about what he means. You need information. Listen carefully. Keys to clarifying. Rephrase the answer or question. And for an example, I understand that you feel depressed and concerned. Or, inmate, I cannot sleep. I stay awake all night. Officer, you're having difficulty sleeping? Offer a general lead. For example, tell me how you feel, or, and then go on. Probe for specifics. Are you concerned about a long sentence? Give broad meaning. Ask an inmate if he would like to discuss something or what he's thinking. This releases tension and despair. The inmate was probably wishing someone would ask what was wrong. If he tries to avoid conversation, say, you really look like you need to talk things over with someone. Seek clarification. I'm not sure I understand. Could you explain? Attempt to put things in sequential order by developing circumstances leading up to present situation. Present reality, in the form of discussing how fantasies can be fun or frightening, but that we must accept and deal with everyday life functions. Suggest collaboration. Introduce the idea of discussing problems with someone else, perhaps to a sensitive inmate that could be a person to relate to. Verbalize. Sometimes detainees may be reluctant to discuss feelings or personal history. In these cases, the detainee has to be encouraged to answer your questions. Often because of his own reluctance or your paperwork and schedule, time is not available to just sit and wait until he feels like talking. When you find yourself in a situation where not much is being said, here are some interviewing tips to help you. Keys to verbalizing. Just nod and say, I see. Restate the last thing said. Summarize. If you have a hunch, express it. This outline does not attempt to give a set procedure, but rather information and tools that, if used properly, can increase your chances of managing people in crisis. Interaction skills. It is important for you to know and understand the interactions necessary for one to successfully intervene during another intervention that you are aware of. Dwelling on oneself. And by letting the individual talk, they may need to vent. Feeling of loss. Show interest and support. Be genuine. Try not to seem canned. Loss of self-esteem. Point out individuals' strong points. Appeal to his or her ego and listen for things like, why should I bother anymore? Everything I do is wrong. My life is useless. I'm useless. Can't even support my wife and kids. What good am I? I'll tell you, no good. Might as well be dead. The detention officer may say, or the employee may say, why don't you try being more positive? Don't you think your wife would rather have you here than not at all? Try thinking more about when you get out of here, being with your wife and kids, and working again. Anger. Express what the person is afraid to express himself. Take the burden away from him. For example, the detention officer may say, are you angry that you were here? Perhaps you think you are getting a bum deal. Feelings of being alone. Involve others. Put in contact with significant others, including the wife, girlfriend, mother, father, close family members. Cry for help. Assure the individual about your willingness to help. Anxiety. Be tolerant of individuals and your own anxiety. Don't lose your patience with their depression and your own uneasiness with the situation. Common methods of suicide. Common methods include hanging, cutting, like the wrists, drug overdose, drowning in a toilet bowl, ingesting a hazardous material, poison, death by trauma, so like jumping off the top tier, or other methods like suffocation by plastic bags, ropes made out of toilet paper, etc. Following a hanging attempt. While there are many ways suicide while in a detention facility, the method of attempted suicide by hanging will be discussed because it's seen the most frequently. And a person who has appeared to have attempted suicide in this manner, you should do the following. But remember, before I start this, remember scene safety is the most important thing. Don't go running into a cell to save someone who's hanging if you don't have anybody there to back you up. Alright, so cut down the victim, protecting the head and neck as much as possible. Victim should be held up by one person while another cuts or removes the noose. Caution. Some jails fail to revive suicide victims because several minutes are spent trying to locate an instrument to cut the noose, which is sometimes thick and difficult to cut. Seatbelt cutters used by rescue squads are excellent for cutting through tough material. Some jails require officers to carry this instrument with them at all times in a case attached to their belt. Unless circumstances clearly indicate a homicide, the occurrence of a suicide should not be treated as a crime scene. But we do, so that we can do a full investigation. Have someone immediately call 911 as policy and procedure outline. Give basic first aid, so we monitor and maintain an open airway. If there is no pulse, we give CPR. Be advised that only a physician or qualified professional as designated by state law can pronounce an individual dead. Until such time, first aid and CPR should be started and continued. Assume that the inmate has a spinal cord injury and treat appropriately. On the floor with the head held stable. Do not let the victim or anyone else lift or twist the head. Give them nothing to eat or drink and no medications. If there is swelling or discoloration, apply an ice pack to the area and do not leave the victim alone. Again, many of these things, after we cut down the victim, medical personnel will be handling and then EMS personnel. The biggest thing is do not leave them alone until they are with the appropriate personnel. So there's some legal considerations to suicide in our facility. This section is not intended to provide all the information concerning the legal considerations and responsibilities in a detention facility. More information is addressed in other aspects. The detention facility is charged with the duty of care. We are charged with doing a safe living environment, protection from physical harm from both self and others. We have a foreseeability. We have to have knowledge of suicidal risk of detention facility population. We have to have knowledge of the effect of alcohol and drugs on suicidal tendencies. We have to have knowledge of the impact of the detention environment on suicidal people. We have to have training in screening, supervision, and monitoring. We have to have knowledge of departmental policies and procedures. We have to have knowledge of actual suicide attempts while in custody, a statement of intent, a history of mental illness. A healthcare provider determines and recommends precautions, detainee's emotional state and behavior, and circumstances surrounding the detainee's arrest. In the officer's defense, we always act in accordance with what the good law calls good faith. We have to keep good records that are clear, concise, and factual. Use good common sense. Obtain legal counsel to assist in the defense for the agency and for the independent officer or employee. While suicide remains the leading cause of death in our detention facilities, efforts towards prevention continue to show steady progress. Importantly, among these efforts is training of employees in recognition and prevention. We have discussed certain signs and symptoms exhibited by inmates which foretell a possible suicide and, if detected, could prevent the incident. What an individual says and how he acts while being arrested, transported, and booked are all vital in detecting suicide. Properly trained personnel can assess possible suicidal conditions during the booking and intake stage. We've spent this time discussing critical information and skills about suicide identification and prevention. It is essential that all policies and procedures regarding screening forms, preventative techniques and measures, referrals and guidelines be developed according to individual departments and governing officials, which we have. This program cannot succeed unless staff knows what to do with an identified high-risk inmate. It is imperative that training regarding suicide prevention be a continuous and ongoing process in each department. If you have any questions, please contact me at sfox@nhcgov.com at any time, and I'll be happy to help you. If you have any questions, let me know. Thank you for your time and attention with this training.